73-year-old female presented with palpitation and dyspnea on effort. Electrocardiography showed atrial fibrillation, and transthoracic echocardiography revealed atrial mitral regurgitation with LA enlargement and reduced LV function. Transesophageal echocardiography showed significant regurgitant jet with non-circle wide regurgitant orifice along with coaptation line. 3D color Doppler nicely shows the typical curtain-like regurgitation commonly seen in functional mitral regurgitation. Annulus was enlarged mainly in intercommissure direction in this particular case. Although the degree of atrial mitral regurgitation was significant, we discussed the possibility of LA reverse remodeling after successful catheter ablation and referred her to catheter ablation. Quantitative analysis of the mitral valve complex was performed using dedicated analysis software. Here I present the catheter ablation procedure operated by Dr. Keiichi Ashikaga with the use of a 3D mapping system, the Cardiothoracic system. As the initial preparation for the 3D mapping, 3D Cite image is now fused with an intracardiac echo image. The anatomical positions are roughly matched by looking at the images of the aorta and the left atrium as landmarks. As the next step preparation, the magnetic field in the right atrium is now set under the guidance of marched CT image by shifting the ablation catheter. Firstly, define the superior vena cava position and then down the catheter to the lower position of the right atrium. This process is needed for a unique ablation procedure without fluoroscopy exposure, which allows an operator to identify the sheath without fluoroscopy. Then the deflectable sheath is now inserted into the right atrium, now going up to the superior vena cava. Here we are looking at the broken draw procedure under the guidance of intracardiac echo. Now we see the right atrium with clockwise rotation. We see aorta and then left atrium. Now we see the septal tenting and puncture of the intraatrial septum. Then the guide wires now inserted into the left atrium. Next, by using the ablation catheter, the marched images are adjusted to identify the precise position of the left atrial walls. This yellow catheter is inserted into the coronary sinus, and this colorful, unique shaped device is a mapping catheter. Now the marched LA images are three-dimensionally confirmed. Fusion of the 3D mapping system and 3D CT image. Here we see the voltage mapping of the left atrial lobes under the atrial fibrillation rhythm. This is the posterior side and then anterior side. Then the extensive pulmonary vein isolation is now started in each ablation point, ablation index, which is derived by the electric power, touching time and force, are carefully checked for the safe and effective ablation. Here we see the point-by-point ablation. We can confirm the ablation point by the red dots. And target ALI for posterior side is 400. Here we see the ablation index here. At the esophageal side, specific high power short duration ablation should be applied to avoid the esophageal injury here. For the anterior side of the pulmonary vein, target ablation index is set to 450. We can see the pulmonary vein potential here, these small potentials, and then the potentials are here, now disappeared, which confirm that the pulmonary vein isolation is completed. Here we see the same procedure for the right pulmonary vein isolation. Point-by-point ablation here around the pulmonary vein. Again, we can confirm the pulmonary vein isolation by the disappearance of the pulmonary vein potentials. Here we see the 3D voltage map and activation map after completing the extensive pulmonary vein isolation followed by electric defibrillation. We can confirm the posterior side and anterior side. This is the final confirmation by the 3D mapping system. We can clearly see the red color around the pulmonary veins. That means no voltage around the isolated pulmonary vein area. In 6 months after the procedure, this patient maintained sinus rhythm and chest X-ray showed marked improvement in cardiomegaly. Degree of functional atrial mitral regurgitation improved to mild or trivial. This is another patient with atrial functional MR who showed significant improvement in MR after catheter ablation. Atrial MR was apparently diminished after maintaining sinus rhythm by catheter ablation. LA volume and mitral annular size decreased. These results show the positive effect of radiofrequency catheter ablation on the 3D mitral valve apparatus with reduced the degree of atrial MR. Early intervention by catheter ablation can prevent progressive mitral valve complex remodeling and thus severe atrial MR in a later stage of the disease. This may reinforce the clinical importance of the early intervention for atrial fibrillation from the insights of prevention of future heart failure as well as future cardiogenic stroke. Severe atrial MR, along with long-ear persistent atrial fibrillation or larger LA size and reduced LA function with greater mitral apparatus remodeling, are generally considered as irreversible, and mitral valve surgery should be needed to alleviate the hemodynamic deterioration.